scientist and remains a vibrant force in developing therapies for adrenoleukodystrophy, and he's going to tell us about some of his research now.
Thank you, Doug. It's just a great honor and pleasure to be here, and it is just wonderful to see the interaction between the patients, families, and the research groups. It's so much to Doug's credit and everybody else associated. I am going to speak to you about novel imaging strategies, which is the work of a great many people. I particularly want to talk about two associates, Dr. Seth, or Mr. Seth Smith, who is a doctoral student working intensely on imaging, and his data will be the pièce de résistance of my talk today. And then Dr. Prachi Dubey, who is very intensively involved with it and is here today. Now, I'm going to talk to you about imaging strategies, and I'm using as a representative model a disease called adrenoleukodystrophy. It has been popularized in the movie called Lorenzo's Oil. People remember that name. They can never remember the name adrenoleukodystrophy. Why am I using this as a model for you? The reason is that somewhat analogous what Dr. Kerr has done. We have identified 4,000 patients with this condition. It is actually my wife, Anne, who developed the diagnostic technique for it. And the reason why it has applicability here is that it is a disorder that can be diagnosed exactly. It can be identified at birth. We know, unfortunately, that all of those patients will develop neurological involvement at some time in their life, be it childhood or adulthood. And we can therefore analyze, we can identify patients who, again, unfortunately, will develop a neurological abnormality of spinal cord or of brain. And we can then trace the very earliest onset of it and see what happens at those points. The other reason why we feel that it is relevant, there are two types to this disease. There is an adult form, which is non-inflammatory, involves the spinal cord only, and involves primarily the axons in the spinal cord. And then about half of the patients will get an inflammatory disease, which is an intensely inflammatory demyelinating disease, which bears resemblance to multiple sclerosis. In addition, some of the men who start with a non-inflammatory form will convert to the inflammatory form. So at that point, with modern techniques, including the cytokines, IL-6, all the other studies that have been referred to, we can then understand what is happening in people who are turning from the non-inflammatory to the inflammatory types. So this is a reason why I feel that the work that I will be presenting is not without relevance to the transverse myelitis group. Oh, I'm sorry. Now, X-linked adrenoleukodystrophy affects the nervous system, white matter, and in the axon, the adrenal cortex, and the testis. X-linked, it means that it is on the X chromosome. There is an abnormality, which is the accumulation of what are called very long-chain fatty acids. And they are abnormal in the blood and are already abnormal on the day of birth. And then the gene defect has been exactly identified. So unlike some of the other disorders that were discussed earlier today, such as depression, we know exactly whether somebody has this disorder or not. So we can really focus our studies on an extremely well-characterized group of patients. Now, as I mentioned before, about 35 to 40% have the rapidly progressive inflammatory type, which is associated with an inflammatory demyelination in the brain. And then the other half have this non-inflammatory involvement of the long tracts in the spinal cord that involves the axon mainly. To give you an example of the inflammatory type, the symptoms, these are boys, the symptoms never start before 4 years of age, most commonly come on around age 7. They're boys who had been perfectly normal and then develop something that looks like attention deficit disorder, attention deficit hyperactivity disorder, or learning disability. And this is a little boy who presented there. You can see that is the organization of his writing toward the end of the line is poor. But then what makes it so different from attention deficit disorder, that within 8 weeks, this is what happened. That is, he was a boy who had developed perfectly normally, then at age 4 or 5 developed that something that looked like attention deficit disorder, and then had this crashed with his nosedive, shown here in his handwriting, and he went on to total neurological disability and death within 2 to 3 years. So this then is the childhood form of the disease, and then this is the adult form of the disease. These are men with spastic paraparesis, well enough known to all of you. Then they may have this hyperimpigmentation associated with adrenal insufficiency, or they may not. It may come on relatively late in life. We had one man who was worked on high steel in his 40s, and then developed the adult form, which developed a progressive paraparesis, but he lived to his 70s, and some of the men are now in their 80s. One of the other features that is so puzzling and such a challenge to those of us concerned with the disease, this is a family where this boy was diagnosed at 10 years of age because of the classical childhood form, like I described to you earlier. He had an 11-year-old brother, 1 year older, who had the biochemical abnormality, was perfectly normal. He has a 3-year-old cousin who has a biochemical abnormality, is perfectly normal. You can see this is X linkage. It is transmitted by the mother and to the son. What is a striking feature here is he has a maternal uncle who is a police officer in Buffalo, 54 at that time, does all the things that policemen do, chases down criminals, and he was found to have the biochemical abnormality. When his reflexes were examined, the reflexes in his legs were a little bit increased, but he was perfectly without symptoms. He would never have thought that there was anything wrong with him, were it not for these relatives, the blood test having been done. When a man with adrenal myeloneuropathy has a daughter, since he is the only source of the X chromosome, the daughter has to be a carrier. So here then, for genetic counseling, it became extremely important to know that this is the case. And we have studied 1,600 family, and we know of 14,000 people. We have identified those who are at risk. I will not belabor this point further because that's not the main point of this talk. What I want to talk to you about today are the application of imaging techniques to the study of this disease. And I will show you that the methods of imaging in this instance, particularly spinal cord, that have been developed in the study of this disease, I will believe, or are very readily applicable both to multiple sclerosis and, I believe, transverse myelitis. Now, this is the classical magnetic resonance imaging. There's a scoring system has been developed. The abnormality in this patient is a little bit increased white matter here. And this is a part of the brain that makes visuospatial coordination, and the learning deficits and disorders that resemble attention deficit disorder are related to that. Sorry. Excuse me. Okay. I'm going to go through very quickly through this part. Let me just say, by this slide, we have developed a formula by which we can predict how much the MRI of a patient would, in an untreated patient, would get worse during the next 12 months. This finding is very valuable for the study of adrenoleukodystrophy, but not particularly relevant to this problem, so I'm not going to pass on and discuss it more. Now, I do want to point out the inflammatory nature of this rapidly progressive childhood disease. This is what is called the T1 image. The disease in children involves mainly the parietal lobe, occipital lobes, and this is why that area under this, what is called the T1 technique, is particularly dark. What is important here is this halo, which is the accumulation of what is contrast material. So this slide shows that the blood-brain barrier is broken down in this exact region. This is where the pathology of the disease is and where it is advancing. Now, we have found that patients who have this enhancement, we studied a group of 22 patients, and all of those patients advanced rapidly. We then had another group of 22 patients who had some white matter abnormality but did not have the breakdown of the blood-brain barrier. And 85% of those patients did not advance. So this is one of the demonstrations, among others, of the importance of the blood-brain barrier disturbance in terms of progression of an inflammatory disease and of an immune-mediated disease. Now that point has relevance to what you were studying. Now, in adrenoleukodystrophy, unlike multiple sclerosis, it is a large single lesion which gradually advances. In that respect, very different from multiple sclerosis, where you have lesions all over the place. Here, we find this is where the classical MRI is very abnormal. And then this part of the brain under classical MRI looks rather normal. But using mass spectrometry techniques, we find that the choline peak, which is an indication of myelin breakdown, is already abnormal even in these distal regions. And as the untreated disease advances, one can see it creeping up. Now, one of the points that and this is an example, what I've talked to you about initially was a conventional magnetic resonance imaging, and I showed you that the presence of enhancement on gadolinium has a great deal of predictive power and is very valuable. Now I'm introducing another technique called magnetic resonance spectroscopy. The main point here is that a peak called N-acetyl aspartate, NAA, is a marker of the axon of the nerve fiber, whereas choline is a marker of the myelin sheath. Now, in the slides that I'm showing you now address a point which is of particular interest in relation to multiple sclerosis. In multiple sclerosis, as I think many of you know, there is increasing recognition that damage to the axon plays an important part. In multiple sclerosis, it appears very likely that the inflammation of the myelin sheath is the first event, and that the axon is damaged secondarily. Now, we find in adrenoleukodystrophy that is different. In adrenoleukodystrophy, the first change is a diminution in this peak, N-acetyl aspartate. Now, we found this is a patient who has early adrenoleukodystrophy. This little lesion here in the white matter, these are the ventricles, but it is this white matter abnormality which was characteristic of ALD. Now, what we have found, then we look at the magnetic resonance spectroscopy in those areas right next to the abnormal myelin, we find that some patients, the spectroscopy is abnormal in the region right next to the myelin that is definitively abnormal by MRI. This is such a patient. Now, both of these areas, which look normal under MRI, are abnormal under spectroscopy. We have then found that all of those patients in whom the white matter adjacent to the known abnormal white matter was abnormal if one used spectroscopy, all of those patients advanced. in contrast, the patient here, who, when we examined the area right next to his abnormal myelin, the spectroscopy was perfectly normal. And this patient did not advance. So we believe that by using spectroscopy, we can predict whether the patient has a disease that is going to be progressive or not. This, of course, is of critical importance in knowing whether to recommend therapies such as bone marrow transplantation, which we know can be of help in people with a progressive disease, but you don't want to offer a dangerous procedure as transplant to people who are not going to progress without it. So these, this is work performed by Dr. Dubé, who's sitting here. And it's a concept that is important to adrenoleukodystrophy. We have looked then at the magnetic resonance spectroscopy in men with the adult form of adrenoleukodystrophy whose brain MRI is perfectly normal. So by ordinary techniques, we would say this is a man who has an involvement of the spinal cord, and they have it severely so, may well be in wheelchair bound, but his brain is unaffected. And it is the man. We have a man who is a judge in San Francisco, others president of the railroad company, has the spinal cord form of the disease, but his mental functioning is entirely normal. Yet, when Dr. Dubé looked at the marker of axonal integrity, she found that there is some disturbance of the axons in the brain, indicating to us, and this is the more generalized principle in this next slide, then there are a number of lines of evidence suggest that in adrenoleukodystrophy, the primary pathology involves the axon, and that then there is an event where as a second event, the white matter becomes inflamed and an immune-mediated response develops. Why am I telling you all this? The point is that we have a set of patients who we can follow very carefully. We can determine precisely, neuroradiologically, the point at which the inflammatory disease develops. We can then determine by biochemical, immunological study, spinal fluid studies, what is there in this patient that makes him convert from the non-inflammatory to the inflammatory disease. So we believe that this point has relevance to multiple sclerosis and perhaps to some extent to transverse myelitis. Now, the points that I want to talk to you about now, which are the closing points that I will make, are new techniques which very clearly have relevance to transverse myelitis. This is the neuropathology of the adult form of adrenoleukodystrophy, the non-inflammatory form. Dr. Powers has shown, these are what are called the dorsal columns. This is a part of the nervous system that transmits position and vibration sense. And this is a part that bears the main brunt of pathology in the adult form of the disease. Now, it is very difficult. One can beautifully show, or one can very clearly show, abnormality and myelin in the brain of patients with multiple sclerosis. It shows up all over as the little white spots that we show all the time. In the spinal cord, this is the spinal cord, it is very difficult to differentiate gray matter from white matter disease. If one images the spinal cord of patients with the adult form with conventional techniques, one can show that the spinal cord is a little thinner than it should be, but otherwise you cannot take it further. So what Seth Smith, who is the person who has devised the advance that I will show you, he is enrolled in the Johns Hopkins School of Engineering and is a student with Dr. Peter Van Zyl, who is the director of what is called the F.M. Kirby Center at the Kennedy Krieger Institute. The institute is right next and connected to Johns Hopkins. It's an independent administrative organization, but everybody has to have and has appointments at Hopkins. And you know, we are within 50 feet of each other, and actually all of the research imaging in neurology department is done in the Kirby Center at Kennedy Krieger, which is a very nice example, I think, of the interaction between the two institutions toward a common goal. Now, the magnetization transfer technique, the point of it is when myelin is normal, most of the water is bound up either in the axon or the myelin sheath, and there is little free water. When the myelin sheath or the axon are broken down, then the free water content increases a great deal. One cannot image free water. Magnetic resonance, magnetization transfer, one applies a brief pulse which converts this to that, and then if there is very little bound water to start with, then the magnetization transfer will not show much change because most of the water is free to start with. On the other hand, if the axon or the myelin sheath are intact, there is a great deal of shift. And the degree to which this shift occurs is then the basis of the method. Now, this is what Mr. Smith has accomplished by using this technique in the normal spinal cord. Here's the spinal cord. You see the gray matter, and the white matter is dark because it has more bound water. So this is what the normal spinal cord looks like. Without this technique, one could never get that degree of separation between gray and white. Now this is what happens, and then the trick that Mr. Smith introduced is that magnetization transfer has been used before, but it didn't give a good separation. He found a technique to normalize the data to the same image. Now, to describe that more exactly is more than I personally know how to do, or is your point of interest. But you can see, again, in the larger picture, how nicely the gray matter shows and the white matter in this image is dark. Now this then is patients with the adult form of the disease. This is a normal person. Here is a person in the early stage of adrenomyeloneuropathy. You will see that the white matter, the gray matter, is not as clearly shown, but you see a little white spot. The gray is not as clearly gray as it was before here. And then this is severely involved. You can see that this region, which corresponds exactly to this part of the spinal cord, shows the abnormality. So this is the first time that has been accomplished, and then these are quantitative values, then this is looking at exactly that little area, extremely small part of the spinal cord, and one can actually obtain 25 different planes of the spinal cord. And see, this is what happens in normal people. This is what happens in men with AMN. And this is that happens in women who are carriers for the illness. The carriers have a moderate form of the illness. These differences are absolutely statistically significant. And furthermore, the degree of abnormality correlates with the degree of involvement of the dorsal column as measured by vibration sense. So here then, in this disease, we can look exactly at the structure of the myelin, and we can look at the function of the myelin exactly in the area where disease strikes the most. Now, what is my last slide I want to show is, and this is the slide which was produced only 4 days ago, and it has never been done before. This is the lumbar spinal cord in a normal person. You can see how clear it is, but you can also see how small that region is. So it is, and furthermore, here it's, when we do MRIs, we ask patients to lie still. They do, but the lumbar cord is right next to the aorta, and the aorta isn't going to stay still. It vibrates with every beat. So what Mr. Smith has accomplished by doing an extremely rapid course and by again correlating it to the same image, he's able to show exactly the structure of the spinal cord. And it seems to me that this then will allow a beautiful opportunity to look at the changes in transverse myelitis, to see how it changes over time, to see how therapy is affected. So we are using these imaging techniques to evaluate treatment in adrenoleukodystrophy. The inflammatory forms will require different therapies from the non-inflammatory forms. You can well imagine that the patients who have this illness and know what would happen to them without treatment are rather impatient for us to get going and devise several therapies. We are, in fact, devising a number of therapies and evaluating them. What we hope in particular is that imaging techniques like this will allow us a sensitive, objective, and relatively rapid evaluation of therapeutic interventions. There are a number of therapies we could test, as I can in transverse myelitis and multiple sclerosis. But what I would want to do is to test a number of therapies concurrently, and I believe these neuroimaging techniques will make it easier for us to do so. And this why I think these techniques may have relevance to the issues you are studying. And there are many, many people involved. I wanted to particularly call attention to Prachi Dubey, who's been the main person on the clinical side, my wife Anne, who is the heart and soul of this whole thing, and then Seth Smith, the student in the School of Engineering, who devised this, I think, very significant advance of being able to image the lumbar cord. Thank you. Right.
May not appreciate, those images are unbelievable to see. I mean, it is, you know, we'll look at a spinal cord under a microscope, and we'll see this beautiful anatomy, but you never see it on an imaging. To think that you can kind of get that anatomical resolution with an MRI is something that nobody has ever seen. This is just unbelievable. So, you know, just to kind of reiterate this point, we've all seen MRI as a dramatic advance, and indeed it is, but conventional MRIs are kind of blind. They don't tell you really what's going on in the tissue. What an MRI does very effectively, it says something's not right, but it doesn't tell you what it is, whether it's axons or neurons that are dying, whether it's fluid, whether it's demyelination. It doesn't tell you any of that. It tells you something's not right, and that's helpful. That's good. But what this does is it can, even at a cellular level, really get to what it is that's wrong. That's why it's such a huge advance. And the application of this, obviously, to other spinal cord disorders like transverse myelitis will open up a whole new realm. I mean, you can imagine that, you know, we can now devise therapies specific for what the MRI tells us that is going wrong. So, questions? Yep.
What's that, please? I think the spinal cord imaging, we have not yet done the lumbar cord patients with disease. The lumbar cord was only 4 days ago that it became possible. The cervical cord technique is now in press, so I think applying it to the cervical cord will be the mainstream shortly.
So once these articles come out, then other hospitals will obviously apply this technology. The magnetic resonance spectroscopy, most academic centers can do, not as well. I mean, certainly I think Hopkins has unique advantages, but that will change so that I think many places will be able to do this over time.
The magnetic resonance spectroscopy is used all over the place. I mean, that's a transfer of spinal cord in the cervical region. I will be available in years.
Other questions? Okay, thank you so much.